Everyone, thanks for coming to this Lunch and Learn event hosted by the Injury Prevention Center at the University of Michigan. My name's Doug Wiebe. I'm the director of the Injury Prevention Center. I'm a professor of epidemiology here in the School of Public Health and also have an appointment in the Department of Emergency Medicine in the School of Medicine. It's my pleasure to present our speaker today, who is Dr. Pooja Lagisetty. She completed her undergrad degree at University of Alabama, medical school at Johns Hopkins, and then a master's in health services research here at the University of Michigan. She's an assistant professor in the Division of General Medicine and also at the Center for Clinical Management and Research in the Ann Arbor VA Health System. Her research focuses on addressing access barriers and developing multidisciplinary interventions to better treat chronic pain and addiction across general healthcare settings. Dr. Lagisetty, we look forward to hearing from you.
Thanks so much for having me. I'm really excited to talk about chronic pain amidst the opioid overdose epidemic. A little bit about me, because I understand that a lot of you guys are students, and I know that when I was a student, I always wanted to know how people got to where they are. And so I'll start a little bit about kind of what makes me do the work that I do. And then we'll dive right in. So I'm a general internist, so I'm a physician that practices both primary care, both in the outpatient setting and also inpatient in the hospital. And I'm also boarded in addiction medicine. And I spend about 80% of my time doing research on health policy related to opioid use, whether that be pain or addiction. And I largely focus on how policy, stigma, and racism affect access to care for people with chronic pain and substance use disorders. And so, as you guys heard, I'm actually originally from Alabama. My undergrad degree was in art, and then I went to med school at Johns Hopkins. And much like many of you, I was really interested in public health and took a year off to work for the Baltimore City Health Department, where I really started to kind of think about things from a population health perspective and started to think about kind of disease prevention, whether that be in the addiction space or other chronic diseases. Did my residency in Boston, and that was where I was really kind of first exposed to differences with respect to the opioid epidemic. Not sure what happened here. Hold on one second. Looks like a computer glitch. There we go. Let's see. So, did residency in Boston, and this was where I really started to recognize that disease looks different in different environments, which is not new to all of you. So I had seen kind of addiction in Baltimore, which was largely a large urban, majority black population that was usually using a lot of non-prescribed opioid use for different respective reasons. And then when I went to Boston, I started to care for a population that was largely white, receiving prescription opioids to treat their chronic pain, and were leading into different substance use related problems. And so this was when I really started to kind of think, addiction looks different for different people, and there's different stigma and access barriers for different individuals. And then I came here. I came here actually at the time. There was a Robert Wood Johnson Clinical Scholars Program. Now there's still a National Clinician Scholars Program that's hosted through the Institute for Health Policy and Innovation. And here, I started to practice at the VA. And there I saw a very different look of addiction. I saw a group of young men and older men who had suffered from pretty significant trauma with respect to their time in the service, and were basically struggling with addiction in the setting of their PTSD and other mental health comorbidities. And there was a different kind of cultural phenomenon with respect to addiction and pain for the patients that I was treating here. And so I bring this all together because I think some of these observations will kind of help shape some of the findings that I'll be talking about in the research that I'll be discussing. I don't have any conflicts to disclose. The majority of the research that I'm going to talk about today was funded through the Michigan Health Endowment Fund and also the National Institutes of Drug Abuse. So today's objectives will review the opioid epidemic and treatment landscape for patients with pain. I'll describe some major barriers to accessing pain treatment, and I'll discuss some potential solutions. So this slide is probably something you see in the news a lot. We're in the middle of an opioid overdose-related epidemic. And what you will see in this graph is that, that opioid-related overdoses continue to climb. Although the face of these overdoses is starting to shift, and the substances that are being used or kind of are the main culprits in these overdose deaths are starting to change. As you can see, kind of pre-2010, it was, largely driven by prescription opioids, and as you see more recently, these overdose deaths are largely driven by synthetic opioids such as fentanyl. Not to say that prescription opioids aren't still kind of a problem necessarily in these overdoses, but we are seeing that the drug supply is evolving. So before I start, I want to make sure we have some definitions right, because sometimes when we think opioids, pain and addiction and everything just starts to get kind of muddled together. So when I'm talking about pain today, come on in. I'm going to be talking about long-standing chronic pain. So that is pain that exists for greater than 3 months. And it can affect your functioning and quality of life. Now, on the other hand, there's opioid use disorder, so the acronym OUD, and that is a pathologic pattern of opioid use involving cravings, the inability to abstain, and problems with one's behaviors and interpersonal relationships. Now, these two can be linked, right? Like, you can have pain and an opioid use disorder, but they're not always linked. They can often be separated, and more often than not, they are separated. A lot of people have chronic pain and, let's say, take prescribed opioids for that chronic pain, but they never have a pathological pattern of opioid use. So it doesn't affect their daily life. It doesn't affect their relationships with their spouse or their children. It doesn't affect them getting employed or anything like that. So they're still able to maintain their use of that substance without it becoming a problem. So, who is affected? What are the numbers? We estimate that there are probably 10 million people that are prescribed opioids for acute and chronic pain annually. And this number has slowly decreased with the advent of a lot of the policies that I'll be talking about today. In contrast, with opioid use disorder, we think that there's around 2.5 million people who have an opioid use disorder. So let's start, with one of kind of the first studies that I want to talk about. And in order to do that, I think we need to understand how opioid prescribing policies have affected access for care for patients with pain. So there's been a slew of different policies, and I'm only going to touch on like a few of them just to give you a little bit of an overview. So on the national level, we can think about policies with respect to kind of the Drug Enforcement Agency, and with respect to how they monitor licensing and monitoring for physicians, and what medications are kind of, how they're controlled and regulated. In 2016, the CDC also put out a guideline for opioid prescribing with respect to chronic pain. And as I'll talk about now, that was kind of this perfect timing that really called for judicious use of opioids, but has led to potentially some unintended consequences. Now, on the state level, we have different types of rules and guidelines. So as a physician, for example, I have to fill out an opioid start talking form every time I prescribe an opioid. I have to review the prescription drug monitoring program, which is an online database of every kind of controlled opioid that you've received in a pharmacy. And I have limits on me with respect to kind of dosing and durations. And I know that, there will be sanctions for noncompliance. So there's kind of federal policies and state policies. I'm not even getting to hospital level policies because they can also institute their own rules around opioid prescribing that can vary between different hospital systems. And so all of these policies put together in a very simplified way have led to kind of dramatic decreases in opioid prescribing, particularly starting in around 2010 as they slowly started to become implemented. However, what we realized a little bit after kind of the 2016 guidelines went out, around 2017, 2018, we started to hear from patients and individuals that maybe some of these new policies were getting too restrictive and were leading to unintended consequences for patients with pain. So here's some headlines that kind of capture this. This was an All Things Considered article that said, don't force patients off opioids abruptly. New guidelines say, warning of severe risk. And this was a New York Times headline. Good news, opioid prescribing fell. The bad news, pain patients suffer. And so I was also hearing about this in my own clinical practice. Patients would come to me and say, oh, my last doc cut me off of opioids, and now I don't know where to go with respect to getting pain treatment. And so, this is another one, acknowledging the plight of pain patients in the U.S. And so this really kind of made me think about, like, how do we balance this correctly, right? How do we provide effective pain management with substances such as opioids, which can be effective in certain scenarios, and balance the risk of developing negative consequences with respect to OUD. So before we go into this, we really wanted to think about, well, how should chronic pain be treated? And what we have now are recommendations that say that chronic pain should be treated in a multimodal way with medications, behavioral health approaches, restorative therapies, whether that be kind of acupuncture, complementary and integrative health, and interventional approaches. But this is what we call kind of the gold standard with respect to effective multimodal treatment. And what we know is that for patients to receive this gold standard, they have to often, this is one simplified scenario of how they come in, they have to come into a primary care office. That primary care physician then has to kind of talk to them, come up with a diagnosis, think about their treatment planning. And then the PCP has to often, outside of medications, these other therapeutic approaches, behavioral health approaches, restorative approaches, complementary integrative health, interventional approaches, all of these options have to be referred outside of the general care system. And a lot of these are quite expensive. So the question becomes, can patients taking opioids for chronic pain actually access this gold standard of multimodal pain treatment through kind of general mechanisms like primary care? And so we aim to quantify how these policies could affect treatment access for individuals with pain. And the way we did this is using a secret shopper or an audit study method. And in what we do is we basically called clinics to assess whether patients on long-term opioids have access to scheduling a new primary care appointment. And so we basically had RAs simulate a patient needing an appointment. And this is a method that a lot of other researchers have used in prior studies, largely to kind of understand healthcare access and to avoid response bias, right? So if we just called the primary care office and said, hey, would you take this patient who's on prescribed opioids for chronic pain? They might say yes, but that's because they don't want to be socially undesirable. And so this method kind of helps reduce that social desirability bias. So we called 667 Michigan primary care clinics and asked about, first we said, well, what type of prescribers do you have? So that MDs, advanced practice prescribers, what type of insurances do you take? And do you have any available appointments for a new patient right now? We also asked whether their providers have familiarity with medications to treat opioid use disorder, because we thought that these practices would probably be potentially more favorable towards treating patients with chronic pain, because they would just be more willing to kind of navigate that risk profile. So the RAs called each clinic, and the way we had to do this to avoid too many questions around, like, what insurance do you have, and all the respective questions that you typically get when you call a primary care clinic, and also to mask the fact that many of our RAs were very young and had a young-sounding voice. We said, the RAs called and said, hey, I'm trying to schedule an appointment for my mom. She happens to have chronic pain. They would reveal their mother's health insurance, which was randomized to either be Medicaid or Blue Cross Blue Shield, because we thought there might be a variation by Medicaid. And they said, as they were starting to get the appointment scheduled or the availability, we said, before we get too far, is it okay if my mother's on prescribed opioids for pain? And so, like I said, we randomized the clinic to either a privately insured patient or a patient with Medicaid insurance type. There were 186 eligible clinics, so those were clinics that had appointment availability going into it. And roughly, 93 were Blue Cross Blue Shield, 93 Medicaid. And what we found when we called these clinics was that 41% of our Michigan clinics, basically the moment they heard that the mom was on chronic pain, on opioids for chronic pain, they said, we actually don't think our docs are going to do that, so we can't schedule that appointment. And then on top of it, it didn't really matter whether the patient had Medicaid versus Blue Cross Blue Shield. So this was not a reimbursement issue necessarily. This was something much deeper than that around the opioids itself. So we said, well, why is this happening? And, it could be the administrative burdens, right? Like I just told you, I have to fill out all these forms before I prescribe an opioid. I can only prescribe it for 30 days. And so, a lot of docs were like, well, I don't want to do this anymore. This is just so much work. It takes so much time. I don't want to do it. We also hypothesized that it was probably that they were fearful of sanctions or liability. We heard this a lot, that, I don't want the DEA coming after me. But we also thought, if we took all of those things out of the picture, how much of this is just that they don't want to care for a patient with chronic pain who happens to be on opioids, because this patient population is perceived as potentially difficult or stigmatizing? And so we tried to parse this out, and we did another secret shopper study. And this time we added 8 additional states to make it not just Michigan specific. We picked states by variable rates of overdose, just hypothesizing that maybe states that are harder hit by the overdose epidemic will have increased sanctions or increased laws and policies or kind of increased public stigma around overdose. And this time, we kind of changed it up, and we called each clinic 2 times, not randomizing to one clinic or another. And this one, it was no longer calling for their mom, but the simulated person said, I've been taking Percocet for years, but in scenario 1, they would say, my prior prescriber just retired, which we viewed this as a pretty kind of benign, non-stigmatized reason for needing a new PCP. In scenario 2, on the other hand, we didn't want to be like, oh, I'm doctor shopping or any of these kind of other stigmatizing terms. And so we said, well, I just need a new PCP because my doctor just stopped prescribing it for me. So not quite as green light as my doctor just retired. And what happened this time? So 452 clinics, all of them called 2 times. 75% responded the same to both scenarios. So, right, they have probably the same, clinic policies on opioids versus non-opioids. And 32% said, hey, set up an appointment, we can evaluate you, and we may continue your prescription. 43% said no in both scenarios. So that's the same kind of 41 to 43% statistic that I got at Michigan. So even when we added the other 8 states in, it was still around 40%. And 25%, on the other hand, flip-flopped their answers on both calls. Now, when we looked to see if this was random versus not, we did kind of statistical corrections for this, we essentially found that twice as many of those clinics that flip-flopped their answer were more willing to take on the patient whose doctor had just retired. So that means in these clinics where the administrative burdens and the fear of sanctions and liability are held steady, there was still some variability or kind of clinic choice in which patients were going to get let in the door versus not. And so we're now saying, all right, well, there's breakdowns just getting your foot in the primary care door, much less getting to this kind of, downstream effective multimodal treatment. And so if your patient can't even get their foot into a primary care clinic, then the counter that we would hear sometimes on these calls was, you should just call a pain clinic, right? Like, just go to the neighboring pain specialist. I don't do that here. And so we were like, okay, well, let's see. So we called 366 pain clinics this time posing as a patient again on long-term opioid therapy, seeking care. And before we got too deep into this conversation, we said, well, first, just tell us which insurances you accept. What are the referral requirements for me to actually get an appointment? What treatments do you offer with respect to pain treatments, medications, injections, behavioral therapy, physical therapy? And we essentially found that half of the clinics didn't accept Medicaid. 51% of them required a referral before accepting you as a new patient, so you had to have the PCP in order to even get to this place. And an additional 23% required a referral just based on your insurance. So if you had, like, for example, Blue Cross Blue Shield, they mandated the referral, but if you had some other insurer, maybe they don't. And then the other thing that we found was this multimodal treatment of kind of procedures plus medication management plus behavioral therapy. Only like 10% of these clinics were equipped to do all three of those, and the vast majority were, basically only equipped to give medications or procedures. The other funny part about this was when we were piloting these calls, we actually said, do you have treatment for cognitive behavioral therapy? So we said CBT, and we actually found that many of the clinics were like, CBD? Yes, we do offer CBD. And so then we were like, oh crap, we need to change our piloting to actually ask about cannabis products as well. And it was fascinating. There was far more clinics that offered CBD products than CBT, which I'm not surprised by. So, what are a lot of these barriers? And I'll touch on these briefly. But we know that this is multifactorial, right? There's policy issues, there's payment, there's care coordination between PCPs and specialists, there's stigma, as we talked about, and there's also racial inequities. And so touching a little bit on kind of policies, we know that state and insurer policies around prescribing can add significant administrative burden and fear of litigation, which, as a whole, reduce provider willingness to treat this patient population. And as I talked about earlier, there's all these prescribing kind of guidelines and policies that have come into effect and they all kind of came into effect all at the same time. And so it made for kind of, in some ways, an easy scapegoat to be like, well, it's all these new policies. That's why I can't prescribe to you anymore. And we know that not just through our work, but through other surveys that have been done, that 58% of providers changed their practice due to the 2016 CDC guidelines, which we'll talk about have been revised, but we'll talk about those revisions right at the end of the talk. And 43%, similar again to the same 40% number that we found with our audit studies, are just saying, oh, we're not treating pain anymore. And they often fear this liability, and they say that over and over again, but that is one of their big reasons. And so we tried to, follow this up. We did some qualitative interviews with 25 stakeholders. We included patients, clinicians, and this time we also included office staff, because when I presented those audit study data, this often happens with, data that calls out stigma, to my colleagues, other physicians, their response was, well, that's not me, that's my front desk staff. I'm not doing that. They're the ones who are saying no. I don't have control over who gets scheduled. And so I was like, really? Is it the front desk staff? And maybe there is some truth to that. The front desk staff is the kind of often, unfortunately, the people that are having to field multiple phone calls for refill requests and things like that. And so maybe there is some kind of burdening on them that we're not appreciating. But we really wanted to kind of dig deeper to this. And so what did we hear? We heard that the DEA has scrutinized everything. Extra time and paperwork involved in trying to get meds approved. The legal environment is such that we are cautious about writing anything. We also know that there's payment-related issues, so with respect to cover and reimbursement. So a lot of times people will say, well, I just don't get compensated for providing especially kind of in-depth conversations or some of these multimodal treatments as opposed to, let's say, a quicker procedure that reimburses much higher. And so, PCPs largely have less than 20 minutes per visit for all topics, not just your pain, but your diabetes and your heart disease and everything else and your, 10 medications that you're on. And even though a patient might be really wanting to talk about their pain, these other medications have to get addressed as well. And so we also know that there's big variation in coverage for pain-related care. So 90% of all public and private insurer plans cover physical and occupational therapy and chiropractic time, but they visit their limits, and prior auths are often common for these treatments. And so you have to fill out, again, paperwork in order to actually get this done. So, and then there's less than 10 states that cover some of these complementary alternative medicine approaches. So, similarly, our staff in our interview said, I just don't have time for the conversation. It kind of gets us out of having to accept the patient if the insurance isn't going to pay for it. So again, another scapegoat type comment. We have quite a few Medicaid patients, and a lot of pain management providers don't necessarily take that, so it's a long time for them to get in. What about care coordination? Lack of coordination between providers can result in gaps for effective multimodal pain care. And it's also additional burden on our patients to manage multiple opinions and treatment options. And so, when you've got a pain specialist that's different than the provider that's providing behavioral support, and that's different from the provider that's providing alternative therapies like physical therapy, it gets really complicated really quickly. And so our clinic staff also commented on that. Because of all this, we just don't do pain management. There's not enough counseling agencies that deal with chronic pain, which in their opinion was a mental illness. And chronic pain is a multi-system issue that requires a PCP, a pain specialist, and a psychotherapist for their mental health. We're talking about 3 things here. And then how about stigma? So stigma around chronic pain and addiction make it difficult for this patient population to find a primary care doctor or receive quality of care when they do. And what is the role of stigma? And I'm going to distill this down. This is a really big simplification of it. But stigma for pain is complex. So first, pain is something that we feel. And unfortunately, there's not great objective measures in the clinical setting for pain, right? We can get an X-ray, and it might show that you have a dislocation, for example. But that dislocation doesn't necessarily mean that is what's accounting for your pain. If I X-rayed all of you, we all probably would have some dislocations. And so there's this disbelief around pain, right? There's no lab test that I can order that says, your pain must be severe, versus somebody else's pain is less severe. Similar to let's say diabetes, where I can order an A1C and figure out where you are in your disease spectrum. And so this sets up for a disbelief in a person's pain, where physicians are, we'll find them trying to distinguish between real pain or not real pain. And even using the word real is stigmatizing. Organic pain versus inorganic pain. Again, stigmatizing language where me as a physician is trying to distinguish between whether you're having pain or not, which, at the end of the day, probably isn't my role. I should just believe that your pain is real to you. There's also this fear or assumption of addiction, right? That any person on an opioid is addicted to that opioid. We have patients that even use that language who are on prescribed opioids. They'll say, I'm addicted to the opioid because they've been on the opioid for 10 years. Now, they don't technically meet criteria for addiction because they're still functioning in their roles and responsibilities. They're physically dependent on that opioid, but they may not be addicted to that opioid. However, with studies questioning the efficacy of opioids for pain in certain scenarios, there's becoming this kind of overlying public perception, which, clinicians are a member of the public, that any use of the substance of opioids is, you may have some underlying addiction. And then on top of it, like I said, there's the idea of the illegitimacy of opioid therapy, that in any scenario, it's illegitimately used, right, at this point, right? There's no reason to offer an opioid. And so when you have all of these three different kind of intersections of stigma, it becomes quite prevalent, and it becomes really challenging for a patient to build a trustful relationship with their provider. And so we heard kind of, terms that were, I think, in some ways trying to get at some of this stigma. Mental illness overlying the use of chronic pain medicines, unseemingly, I guess, patients that are kind of drug seeking, which that terminology is also stigmatizing, that have a lot of issues. Now that's really going back to the point that I made, that most chronic pain patients don't need opioids, they need care for their pain. And then what about racial disparities? Differential pain treatment is provided to patients based on their race. And racial and ethnic minorities have reduced access to health care in general and specialty care in particular. There are studies that have shown that pharmacies located in minority neighborhoods are less likely to even carry sufficient analgesics than those in white neighborhoods. And other folks have shown that Blacks and Hispanic populations are less likely to receive an opioid medication than whites. They receive lower doses of pain medications, and they experience longer wait times to receive pain medication. They're also more likely to have a referral to a substance use disorder provider when they do present for their pain or for opioids, fewer referrals to a pain specialist, and increased urine drug testing compared to their white counterparts. So why is this happening? They're likely to experience miscommunication and misinterpretation about pain with their medical providers. Some doctors choose to believe that pain levels are lower for Blacks than whites, or that minorities are drug seekers. And they're also more likely to underestimate the amount of pain that African American populations are experiencing. So how do we fix this? What we've been doing, isn't necessarily addressing the opioid overdose epidemic. Because as a reminder, it's not an opioid epidemic, it's an overdose epidemic. And the overdoses are still going up, right? We've corrected the prescribing, but the overdoses are still going up. And substantial barriers to care exist for patients with pain. And maybe some of these policies have caused the pendulum to swing a little too far. However, there's little appetite for repealing these policies, right? Like if we go back to the state lawmakers and we're like, oh, can you just take some of those things back? Nobody wants there to be more opioid prescribing, irrespective of what's happening with the overdoses. And so it's going to be hard to take things back. So where do we go from here? So this was work that we wanted to do to kind of basically answer that question. And we convened stakeholders from across Michigan in 2020 and 2021 using a modified Delphi expert panel, which basically uses repeated surveys to reach convergence and opinions on how to solve a big problem. And the objective was to create a prioritized list of recommendations to reduce treatment access barriers, specifically for the patient population that was taking prescribed opioids for chronic pain. And what we did was, each recommendation that was provided by this group had to be scored on its feasibility of being implemented, its impact, so if it was implemented, how big impact would it be, and its importance. And ranked by implementation priority. So they had to prioritize their list as well. We had 24 panelists across the state of Michigan, patients, payers, policymakers, clinician experts. And they basically created 11 recommendations. And I'm not going to go into the detail, but there were three major themes. One was improved care models through reimbursement reforms. And this was largely driven by the idea that if multimodal care is the gold standard, then somehow we have to shift reimbursement policies to finance multimodal care. If opioid reduction is a goal, then providers need to have time to have that conversation as well. But currently, the reimbursement models are tipped towards procedural care or towards quick medication type care. And so these need to be shifted. The second one was to enhance provider education around how to effectively treat chronic pain. And the third was to address racial disparities in care. And the three recommendations, including the top two, were increase reimbursement for the time needed to treat chronic pain, and to establish coordinated care models to bundle payment for multimodal pain treatment. With respect to provider education, there was an emphasis on non-pharmacologic care and reducing stigma towards opioid dependence and OUD. And with respect to racial disparities, focus on reducing the impact of provider bias, particularly through the use of standardized protocols and implicit bias trainings. And so this was kind of the conclusion, with some combination of these three kind of recommendations could meaningfully improve access to care. So around the same time, because of all this kind of work that was coming out, the CDC released a new guideline in 2022, basically saying, we're sorry, maybe the pendulum did swing too far. Let us come out with this new guideline. And this new guideline placed increased emphasis on patient-centered care rather than strict adherence to dosing thresholds. So they basically said, in case your state or health system has set some sort of guideline on, like, you can't prescribe over 90 milligrams, don't do that. Patients need to be a part of this conversation when they're coming in for pain-related treatment. They discouraged regulatory bodies from using guidelines that were kind of one-size-fits-all. And they really wanted to increase discussion in primary care settings around multimodal treatment. The other thing that they did, though, which I think kind of personally still creates some problem for clinical providers, is they still use the same language that they did in the 2016 guidelines, which is to say that clinicians should weigh the benefit of the harms of prescribing their opioids for their pain versus the benefits of prescribing opioids for pain. And so this is an editorial I wrote with Dr. Cortez, and we basically make the argument that when you put the word benefit in and you have a clinical provider workforce that may have kind of hard beliefs against any benefit of opioids, as I've just stated, right? So there's a good percentage of us that say, well, no opioid is ever beneficial in almost any scenario. Then every time there's a patient-centered conversation around the harms of the opioid versus the benefit of the opioid, the balance will always tip towards harm. And so the patient is always going to be in this relationship where the provider perceives more harm than benefit. So it's like the conversation's done right when you get in the door. And so we basically make this argument that maybe if there was more discussion around the harms of continuing or prescribing that opioid versus the harms of removing said opioid, because we have emerging literature that removing the opioid can also lead to increased suicidality or mental health consequences or conversion to illicit opioids, then maybe this makes it a little bit more balanced towards a meaningful patient-centered discussion. Now, this is nothing novel. This is harm reduction, right? This is harm reduction that we practice all the time in the space of addiction, which is where the word harm reduction was essentially coined. But this is now harm reduction of opioid prescribing in the context of pain. And maybe that harm reduction kind of framework also releases prescribers from a lot of that liability concern that they're worried about. They can say, I think I'm going to keep giving this person this opioid because I think the alternative is that they will get that opioid from somebody else, and that opioid might be tainted with fentanyl and therefore increase their risk of overdose. And so while I don't really want to give this prescribed opioid, I'm reducing that patient's harm risk profile by giving them that opioid. And then it becomes a slightly more balanced conversation. So this is something we just wrote and just got published, and we're kind of been talking about this idea of restructuring how we essentially, hopefully train folks to be thinking about this. So in conclusion, lots of issues here. Care for patients is deeper than it appears, right? Multimodal treatment is hard. And access to these treatment is difficult for patients with chronic pain. And then if you add on that if you are from a minority population, it's even harder. And this, I think, is a good example of where the policies were all well-intentioned, yet they inadvertently led to some harmful consequences. And so for you guys, who are at the School of Public Health, it's often, it's hard sometimes for us to anticipate the downstream negative consequences from some of the policies that we enact. So, I do this work with a big team, lots of collaborators and research assistants, and open to questions. Yes. Are we supposed to do this thing?
Thanks so much, Dr. Lagisetty.
Yeah.
And yes, we only have one microphone. Perhaps ask your questions loudly, and if you could repeat them,
That sounds great.
that will work well.
I think I'm pretty good at being loud. Thank you. I was wondering about how gender or gender identity may have played a role if you observed anything, like especially with the first one being for my mother as opposed to for my father.
Mm-hmm.
Continuing with like how does the voice sound to the caller?
Yeah, no, these are really important issues with respect to audit studies and the way they are done. And so in our scenario, we definitely said our mother. We didn't have any randomization for my father, which would have been interesting to pick up. But other people's audit studies, and including our second one, people have tried to randomize the name, right? So kind of thinking about racially context names or ethnically specific names. People have tried that to kind of avoid any kind of anchoring to the name of the patient. The other thing that is specific to audit studies that we could not get around, my studies were led by a team of, recent School of Public Health graduate students, and in general, just a lot of young voices, and so we couldn't, and I think we were majority female. There was one male caller, and so then we basically had to take the male caller out of the mix because we were worried about that. And so, we had only female callers, but it is a point that other audit studies that are done kind of on a larger scale and a larger budget have to really kind of think about. Other questions? Yes.
I'm sorry. Yeah, go ahead.
Hey, Mary. Yeah, so the question was, why is it so hard for multimodal care to get reimbursed? So I think it's twofold. One, a lot of the therapies that are endorsed with respect to multimodal care take longer and take a specialized workforce to deliver them. And so there are shortages in that specialized workforce. But I'll be honest, my kind of more cynical perspective on this is that the folks that are at the table when it comes to like RVU reimbursement are pain specialists. And these pain specialists are coming to the table with a very procedural mindset in mind. And so if you think about pain specialists, they don't join their field to necessarily treat chronic pain. They join it to kind of find a lesion for where your pain is and then, deliver an epidural injection or some sort of specific procedural treatment to kind of care for that pain. Now, that is a very highly technical field. It requires a lot of training. And then these specialists are at the table in order to kind of negotiate higher reimbursement rates for what is being given. The problem is our physical therapist is not at the table. Our behavioral therapist is not at the table. And they can't negotiate nearly as high of a level. Our pharmacists aren't at the table. And so we know that this pain treatment, even the medication management perspectives, are done far more successfully and in a far safer way if we have a pharmacist working with physicians, right? But when a pharmacist, we can't reimburse that pharmacist for that time that they are using to deliver that care, then those people aren't at the table anymore. So, I practice at the VA. I have a pain pharmacist who is far on top of kind of evidence-based therapies, non-opioid-based medications, and can advise and guide and have multiple conversations with patients, to help kind of guide transitions of those treatments. But that's not feasible at Michigan Medicine, and it's because of the reimbursement-related issues. Other questions? Cool. Well, feel free to email me if you have questions, and thanks for being here.
Okay, hold on a second. Thank you. Thank you all for coming. I will close with just a couple. Yeah, we can do it quick. So I'm Sarah Stoddard. I am faculty in the School of Nursing and School of Public Health, and I am the director of the Education and Training Core for the Injury Prevention Center. So this is one of the kind of many kind of student trainee related kind of opportunities and things that we do through the center. We've had some other events recently where we talked about our summer internship program, other things like that. So just a few upcoming events. The Public Health Approaches to Ending Gun Violence conference is coming up in February. There's a little agenda here, but the event is put on by the School of Public Health and the Institute for Firearm Injury Prevention. It's virtual. You don't have to go to all the events. I'm not going to either, but I'm going to go to some of the ones that look more of interest to me. But you can either sign up for the full day or attend pieces of it. They do want you to register though, and the QR code up there links you to the registration. And I'm sure if you also go to their website, you would also find registration there. The next one is the Safer Prescribing series, reviewing the CDC clinical practice guidelines. It's a virtual event. If anyone is already a physician or community health educator, there are credits available for that. Registration is opening soon, so just have a sense that that is coming up in February as well. And then last but not least, our third annual Injury Prevention Research Symposium is also coming up on March 5th. That is in person. It's open to faculty, staff, students, researchers, really anyone who's interested in injury prevention. There are, again, continuing education credits available, and the registration is open, and you can get to that registration with that QR code. And then lastly, if you can take a second, and even on your way out, do a quick evaluation for us. And we really, again, appreciate you coming today. And if you're interested in injury prevention, visit our website too. Think about becoming a member, which is really easy. It gets you on our listserv to send out announcements like these and the event you were at today. So thanks.